squamosal segment, the mastoid segment, the petrous segment, the tympanic segment, and then on the image on the right is the styloid segment. And then I have a little star here that indicates the stylomastoid foramen, which is very important anatomically because that is where the facial nerve exits the temporal bone and goes to the parotid gland. Here's some other normal anatomy. This is the external auditory canal. It's actually the arrows pointing to the cartilaginous segment, and medial to that is the osseous segment. Here, the arrow is pointing to the scutum, which is very important when it comes to pathology like the acquired cholesteatoma or cholesteatoma. And then we have the ossicles here, so middle ear ossicles. The arrow is pointing to the malleus, but all of them can be seen. You can see here this is the malleus, this is the incus, and then it's going towards the stapes. It's in this vicinity. You can't really see it very well on this coronal image. And then here the arrow is pointing to the tympanic membrane, so it's usually very thin, not very visible. And then the top part of the where the star is the epitympanum. The middle star is indicating the mesotympanum, and then the lower star is indicating the hypotympanum. And I will point out that the cochlear promontory is just above and medial to the star that's indicating the hypotympanum. I don't think you can see my arrow, but it's just above and medial to that last star. So that's a cochlear promontory. I just want you to be aware of that as we go through our cases a little later. So here we have some more normal anatomy. So we have the malleus. So on the image on the right, you have the malleus head. The image on the left is the manubrium, which is under the other arrow. And then the red arrow is indicating the incus. So on the image on the right is the incus body, and the image on the left is the lenticular process going to, the long process going to the lenticular process. Then you can see the stapes here indicated by the yellow arrow. And this yellow arrow is actually pointing specifically to the anterior and posterior crura of the stapes. And so the incus actually articulates with the stapes at the capitellum of the stapes. So there's a bony projection, in this case, along the lateral aspect of that crura will be the capitellum, and that's where the incus articulates with the stapes. And then the foot plate, which is the medial to the crura, that articulates with the oval window. And so those are some normal anatomy here on this image. And this image, just some normal anatomy, just so you're aware, this is the petrous apex where the blue arrow is pointing to. The orange arrow here is pointing to the internal carotid artery, which is very important to be aware of the intimate relationship between the internal carotid artery and the temporal bone. And then again, we have the epitympanum on the image on the right, indicating the sort of ice cream cone-ish appearance. So you have the malleus head, which is the ice cream, and the cone is supposed to be the incus body. And then the image on the right shows the manubrium of the malleus and the incus, the long process. And then the image on the left, the second red arrow shows the adytus ad antrum, which is an opening from the epitympanum to the mastoid cavity, which is that third red arrow on that image on the left. And then the green arrow is pointing to the otic capsule and specifically to the cochlea located within the otic capsule. And then on the image on the right, the green arrow is pointing to the basal turn of the cochlea. So there are 3 turns to the cochlea that you need to be aware of. It's the basal turn, the middle turn, and the apical turn. So it's really important to know anatomically. And then the yellow arrow is pointing to the vestibule and the image on the left. And then next to that, the second yellow arrow is pointing to the lateral semicircular canal, which communicates with the vestibule. There's also the superior semicircular canal and then the posterior semicircular canal, which is indicated by the yellow arrow on the image on the right. And then there's the vestibular aqueduct, which is the light blue arrow on the image on the left. So anatomically, these are all very important structures, very small structures, but very important for you to know when you deal with temporal bone imaging. So the facial nerve canal is a very important canal in the temporal bone. The nerve itself cannot be directly visualized on these CT images. So the bony canal defines its course. And what happens is the facial nerve exits the lateral pons and then traverses the cerebellar pontine angle cistern. So that's the cisternal segment. And then it passes through the porus acousticus and courses through the internal auditory canal in the anterior and superior quadrant above the crista falciformis. And then it goes through the petrous bone anterior to the cochlea. And so this is sort of, you can see the first image has a sort of upside down U shape. So that's the first genu of the facial nerve. And so the labyrinthine portion is the more medial, the medial aspect is the labyrinthine portion. Then you have the first genu, and then it goes back. And as it goes back, that's the tympanic segment that goes through, basically through the sort of through the middle ear cavity, I'll say. But it goes to the medial aspect of the middle ear cavity. And then it runs inferior to the lateral semicircular canal and superolateral to the oval window. You can see on the top image, on the middle image on the top and the image on the right, the facial nerve is coursing as a tympanic segment. And then the image on the bottom left shows you the relationship of the lateral semicircular canal above the green little line representing the facial nerve canal, and the lateral semicircular canal is right above that. And then as it goes back, the facial nerve canal has a second genu, which is that middle image on the bottom. So that little green circle indicates the second genu. And then the image on the right, far right at the bottom, shows you the mastoid segment, the descending or mastoid segment through the mastoid bone, medial portion of the mastoid bone, as it exits through the skull, through the stylomastoid foramen that we talked about earlier when we were discussing other anatomy. And then the facial nerve goes and enters the parotid gland and divides the parotid gland into superficial and deep lobes. On MR images, enhancement is normal to see at or distal to the anterior genu or the first genu of the facial nerve, and it's related to perineural and epineural venous plexus. So here, this is an image that I've taken from Amersys. And so this is just how you could see anatomically an illustration of the different segments of the facial nerve. And you can see just from its origin in the pons going through the cerebellar pontine angle cistern, then the internal auditory canal, labyrinthine segment, first genu or where the geniculate ganglion is located, and then the greater superficial petrosal nerve comes off, and then how it goes back and becomes a tympanic segment, and then has the second genu or posterior genu, and then descends down as the mastoid or descending segment. I hope this is clear. I know it's a lot of anatomy, but I have more anatomy. So here's our neighboring structures. It's very important to know. So some miscellaneous structures. So on the image on the left with all the red arrows, the first arrow on the left, that's indicating the mandibular condyle. So that's very important because when patients have degenerative change in the mandible, it can refer to the mastoid. So you can have mastoid type pain or pressure. And so that's something that needs to be looked at when you're looking at the anatomy. The second red arrow indicates foramen spinosum, and the third red arrow indicates foramen ovale. So the middle image, you have the blue arrows, and that indicates the jugular foramen. And so there's the pars nervosa, which is the first blue arrow. It's indicated by the first blue arrow. That's pars nervosa. Second blue arrow is pars vascularis. They are partially divided by the jugular spine, which is that triangular eminence in between, or upside down triangular eminence in between the two. They are located, the jugular foramen is located between the temporal and occipital bones. The carotid space extends directly up to the jugular foramen. The pars nervosa transmits cranial nerve 9, the Jacobson's nerve, and inferior petrosal sinus, and is anteromedial but not contiguous with the pars vascularis. And pars vascularis transmits cranial nerve 10, Arnold nerve, cranial nerve 11, the jugular bulb, and posterior meningeal artery. And then we have the hypoglossal canal, which is the image on the far right. It is located between the occipital condyle and the jugular tubercle and runs obliquely forward, allowing the hypoglossal nerve to exit the posterior cranial fossa. Just so you're aware, the first two images are an axial image, and the last image is a coronal image, and that's how you can see the hypoglossal canal on imaging. And it has that reverse bird beak appearance. So underneath the bird beak is the hypoglossal canal. Okay. So we'll take the first case. So this is a 45-year-old female with hearing loss. So basically, what you want to look at when you're looking at the temporal bone, especially in this kind of a case, is you see opacification of the middle ear cavity and mastoid air cells, and this is on the patient's left side. And then what you're going to look for, scrutinize, is the ossicles. You're going to scrutinize the scutum, the external auditory canal bones. You're going to look for where the facial nerve canal is, especially the tympanic segment that I mentioned to you earlier, that is inferior to the lateral semicircular canal. So if you look at those things, make sure the bones are not dehiscent, because especially in prolonged infection, you can have increased osteoclastic activity, and typically the bacteria that are involved in an otomastoiditis type of situation are streptococcus, Haemophilus, um, and fungal infections in those who are immune compromised. In this clinical situation, it's crucial to exclude complications. So this is why I'm showing this case, because even if you have otomastoiditis, you have to be aware of complications. So it's not just the bony erosions. The bony erosions lead you to think about certain things, like differential diagnosis as well as complications. But one of the complications is this image, which is a different patient. So on the right side and on the image on the left, you see that there is absence of the mastoid trabeculae, or destruction of the mastoid trabeculae. And what happens here is that the mastoids become coalescent. And that coalescent mastoiditis is a complication of otomastoiditis, and it could extend outside the cortex, or to the either to the inner cortex or the outer cortex of the adjacent bone. And if it does, like in the image on the right, here the resorption occurred at the inner cortex. And so the coalescent mastoiditis actually caused, if you can see on this contrast enhanced CT, the patient has, you can see on the left side, the left sigmoid sinus is enhancing, and on the right side, it's not. So this patient actually developed sigmoid sinus thrombosis because of the, as a complication of the otomastoiditis. And in this case, the coalescent mastoiditis caused this sigmoid sinus thrombosis. You can also develop what this is, and basically this is a Bezold abscess that occurs where there's a bone defect at the mastoid tip medial to the insertion of the posterior belly of the digastric muscle. What happens is inflammatory changes are then directed inferiorly, deep to the sternocleidomastoid muscle, and in young children especially, the mastoid tip is not aerated, and so the Bezold abscess in young children is uncommon. And so these are the complications of otomastoiditis. So just a few of them that I wanted to just highlight to you: the Bezold abscess, the coalescent mastoiditis, and sigmoid sinus thrombosis. So those are the things that we've just went over. Other complications include petrous apicitis, labyrinthitis, meningitis, epidural abscess or brain abscess, and lateral temporal bone venous infarct from the vein of Lebet, propagating the thrombosis there. Okay, so the next case is a 58-year-old female with a history of right vestibular schwannoma resection in 2011. She presents to ENT for follow-up, and she still complains of right-sided hearing loss. So if you actually look, this is a axial T2 image on the left, and then a post-contrast T1 image on the right. And if you actually look at the anatomy, you can see the cerebellar pontine angle cistern symmetrically on both sides. And then you see the internal auditory canal on the left, on the patient's left. And then on the patient's right, you don't really see that nice fluid signal within the internal auditory canal. In fact, you don't see the cochlea, you don't see the vestibule like you do on the right, on the patient's left side. The vestibule, you can also see part of the semicircular canals, the lateral and the posterior. You don't see all that on this patient. And so It was recommended that a CT temporal bone be performed because the patient has continued hearing loss on that right side. I mean, she had surgery, but maybe there's a complication related to surgery. And in fact, here the CT shows that there is bone density within the cochlea. As you can see here on the top left image, there's bone density within the cochlea. And then on the middle image, you can see that there's bone density located within the cochlea as well in this coronal image. And then same thing here on the post-shell image. Actually, the Stenver's view image in the middle, and then the post-shell image on the right. There's bone deposition in the cochlea. So this can occur as a result of infection, either viral or bacterial or an autoimmune or post-traumatic. Meningitis has more extensive, it's a more extensive involvement. Um, Basically, what happens here is that there is a ossification in the scala tympani of the basal turn typically. And these ossification of the bony labyrinth is actually called labyrinthitis ossificans. So the etiology is post-traumatic, tympanogenic, so middle ear infection, hematologic, like viral illness, or post-surgical, as in this case. It's typically seen in pediatric patients with sensory neural hearing loss. They have high density bone deposition, as I'd said, in the membranous labyrinth. I like this is a very easy case to diagnose because when you look on MRI, you need to look for the fluid signal. And so there are 3 stages. You have the acute fibrous and ossificans phases. And you need to be specific about where the abnormality is because it helps the ENT surgeon with surgical planning, especially for cochlear implantation. And one thing you need to be aware of is that CT imaging, the findings lag behind MR imaging in the detection of labyrinthitis ossificans. Our next case is a 41-year-old male with changes in his hearing, along with vertigo for 2 years and otalgia and otorrhea that has worsened over the past few months. So here on the images, you see that there's a soft tissue mass in the middle ear cavity and along the cochlear promontory. You can kind of see that there is an ossicle. It looks like it might be the incus on this image on the left. And then moving on, we can see here that you can see the malleus. The soft tissue mass actually envelops the entire incus. And on the coronal images here on the left and on the right, you can see a little bit, this is a little bit more forward where you can see the cochlear promontory. And you can see that there is erosive change. So a cochlear promontory, the differential diagnosis for a mass that is associated with the cochlear promontory, you think of globus tympanicum, globus jugulotympanicum, aberrant internal carotid artery, dehiscent jugular bulb, cholesteatoma, or facial nerve schwannoma. So what you need to do here is kind of look for bony erosion, so ossicular erosion, or look at the scutum, make sure that it's intact. If it's not intact, then you're thinking that this might be cholesteatoma. So in this case, this patient had the scutum on the image on the right is blunted, and then the incus is actually partially eroded. So this was felt to represent a cholesteatoma. So I'll ask, what are the 2 types of cholesteatoma? And so the answer here in this case is congenital and acquired, so B. Congenital is most commonly located in the anterior superior quadrant of the middle ear cavity, just above the opening of the eustachian tube. And acquired is an important complication of chronic otitis media. Where do acquired cholesteatomas typically occur? They typically occur in the pars flaccida, and I'll explain in this image why. So here you have the tympanic membrane. That's a drawing from Gray's Anatomy, and on the right you have the illustration of the tympanic membrane, its relationship to the middle ear cavity, external auditory canal, etc. But the middle ear cavity, you can see, I'm sorry, the tympanic membrane, you can see here that it attaches at the top to the scutum. You can see on the illustration on the right. And the outer portion of the tympanic membrane has 2 layers, and that's the pars flaccida layer. The central layer, where the ossicle, where the malleus actually articulates with, that central area is the pars tensa. That has 3 layers. So I always like to think that the disease process, in this case, the cholesteatoma, likes to go to the pars flaccida more commonly because it has only 2 layers that it needs to break through, whereas a tensa might be a little bit harder because it has 3 layers. So, so the cholesteatomas, there are complications that can occur. So this is why you need to be aware of this diagnosis to be able to diagnose it on CT imaging, especially. You can also diagnose it on MRI because they also restrict on diffusion on MRI, especially, and MRI is useful, especially in those patients who've had surgery before, and there's a concern that there's a cholesteatoma brewing inside the surgical bed. So some complications of cholesteatoma, what they do is they erode the roof of the middle ear cavity, the tegmen tympani, and they may form a meningoencephalocele. Uh, and then there's erosion of the bony facial nerve canal. And I'd mentioned to you the relationship between the tympanic or mastoid segment of the facial nerve canal with the middle ear cavity. It could also erode the bone of the lateral semicircular canal, which may result in the formation of a communication between the middle ear cavity and inner ear, also known as a labyrinth. So that would be a perilymphatic fistula or labyrinthine fistula. So those are some complications associated with cholesteatoma, and it's very important that you are aware of this diagnosis. Moving on to case 4. So this is a axial CT scan, bilateral temporal bone. And you can see here under the arrow, there's lucency in the otic capsule. And I will tell you that the densest bone in the body is the otic capsule. And so it's very hard, it's very bright white. You don't normally see this, but when you do, it's a specific diagnosis. So here's more images showing you the same here. You can see that it's around the cochlea. The red arrows indicating that the lucency is around the cochlea. And then here are some more images. Here's a different patient where you have it where it's anterior. The image on the left shows the lucency anterior to the crura of the stapes. So that's in the fistula antifenestrum. And this is the other image of that same patient where it's in the fistula antifenestrum. But you can also see that there's still some lucency around the cochlea. So this is actually a diagnosis of otospongiosis. So the otic capsule is normally composed of an inner layer of endosteum and an outer layer of periosteum, the middle layer of the persistent primary endochondral bone. In otosclerosis or otospongiosis, which is the term I like, basically what happens is there's resorption and replacement of the dense bone with the spongy vascular bone. And so as it moves on, so you can have the fenestral type, which is the otospongiosis that affects the fistula antifenestrum, which is the most common location, and then the cochlear type is the other type. Retrofenestral rarely occurs in isolation, is most commonly seen with the cochlear type. These patients, the fenestral type typically presents with conductive hearing loss because the stapes then becomes fixed because of that lucency. And then the sensory neural hearing loss is when it occurs around the cochlea. But then if you have both types, then you have the mixed type of hearing loss. And it commonly occurs in females. The treatment here would be stapedotomy, complete or partial stapedectomy, and placement of a stapes prosthesis. So this is otospongiosis. The next case is okay, so this case is a little bit difficult. It's something that I'm not a pediatric neuroradiologist, but I come across these once in a blue moon. And something that you need to be aware of is when you look at the inner ear cavity, you have to evaluate the cochlea, make sure it has 2.5 to 3 turns, and then look at the vestibule, make sure the caliber of it is not dilated, that it's normal. When you see a bunch of temporal bone CTs, you get very used to seeing what normal looks like, and that's really important. In this case, so I want to just direct you to the inner ear malformation. So these are congenital abnormalities. And in this case, it's a cystic cochlear vestibular malformation. You need to evaluate the inner ear structures, as I said. So you have to look at the internal auditory canal, make sure it's normal, it's not atretic or obliterated. You need to make sure that the cochlea has its turns, as I'd mentioned. And the vestibular aqueduct needs to be normal in size. So it's usually in its midpoint, about 1.5 millimeters in size. And then the vestibule is also make sure that it's not dilated. So this basically just bring your attention to inner ear malformations, things like incomplete partition types, Mondini malformation, which is an incomplete partition type 2. So these are different types of malformations that you need to be aware of. It's just something that I'd like to just make you aware what you need to evaluate. If you're not a pediatric neuroradiologist, you can certainly make a better report when you're reviewing in these specific structures. Okay. Next case. So this is a 36-year-old male who presents to the emergency department with hearing loss. So we did temporal bone CT because of the hearing loss, which is very unusual to do out of the ER. But I will show you the abnormality. So here is the abnormality. So this is the superior semicircular canal. You can see that there is no bony covering over the superior semicircular canal. And so this is a specific diagnosis. And the next question is, what types of symptoms do patients feel when they have this type of abnormality? So if you know the diagnosis, you'll know the answer. In this case, the answer, I'll tell you, is superior semicircular canal dehiscence. And patients who have superior semicircular canal dehiscence develop sound-induced nystagmus and vertigo. So that's letter B is the answer for this question. So this is superior semicircular canal dehiscence. So basically what happens is there's absence or extreme thinning of the bone roof over the superior or even the posterior semicircular canal. You can typically see the superior semicircular canal dehiscence on the coronal view or the post-shell view, which is a special view that is done on CT by the technologist. If it's more than 2 millimeters wide, then that's dehiscence. So that's diagnostic. Basically, the patients, as I mentioned, have sound-induced vertigo and nystagmus. So this is called Tullio phenomenon. So under normal physiological conditions, sound pressure is transmitted, right, through the external auditory canal into your middle ear cavity as the tympanic membrane vibrates. And then that's transmitted to the stapes through all the ossicles and then through the stapes that pressurizes the oval window. And then that sound circulates through the cochlea, selectively activating hair cells on the basal membrane. And then it produces sensation of sound. And then it comes out in that closed circuit, goes out the round window of the cochlea and allows pressure to dissipate and transmitting it back to the middle ear cavity. If this superior semicircular canal dehiscence is, if it's present, this is a third window. So what happens is that normal circuit that normally goes from the ossicles, from the external auditory canal to the middle ear cavity to the ossicles, through the cochlea, and then out the round window, actually the third window is there and actually disturbs that, because what happens is as the stapes pushes inward, the covering of the third window pushes outward as well. And that causes slight movement of the perilymph. And that movement or pressure wave in the perilymph compresses the endolymph within the membranous semicircular canal. And the brain interprets that motion of the endolymph as movement of the body. And so the patient feels dizzy. So again, this is the concept of the third window, something that you can read about if you didn't completely understand it as I was explaining. Okay, so this is the next case. This is a case of, this is again another neighboring structure. This is a neighboring structure case. So this is the hypoglossal canal on the right. On this T2 image, there's a soft tissue defect on the left, on the patient's left side, if you can see it. And so which is the only muscle not supplied by the hypoglossal nerve. So the hypoglossal nerve does supply the genioglossus, the hyoglossus, the styloglossus, and the intrinsic muscle of the tongue. The palatoglossus is supplied by the pharyngeal plexus branch of the vagus nerve. So this is actually just a schwannoma of the hypoglossal canal on the patient's left side. Next case, so this is another similar case. So this is a CT done actually for sinus disease, and this is the soft tissue window. And if you look on the bottom image here on the right side of the patient, you can see that there's some hypodensity. And so a CT with contrast was recommended, which was done. And you can see here there's a heterogeneously enhancing lesion in the right. It looks like it's in the right cerebellar pontine angle cistern, causing some mass effect upon the right middle cerebellar peduncle. This is the same patient in MRI image. So you have T1 images on the left, T2 images, and then post contrast on the right. So you can see here that the mass is, T2, it's kind of heterogeneous on T2 and T1 images. the post contrast, it's predominantly enhancing. There's some cystic areas centrally, medially, which is T2 bright. And it goes into the internal auditory canal. And so this is actually a schwannoma of the vestibular cochlear nerve. Um, so here are more images showing you the same. So actually going back, this is actually the ice cream cone. So they show the ice cream falling off the cone, and that would be diagnostic of a schwannoma, where the ice cream is actually the part that's in the CP angle, and the cone is the internal auditory canal portion. So typically this occurs of the eighth cranial nerve, and uh, it basically the patients present with pressure on that nerve so they can have tinnitus, disequilibrium. The treatment is basically surgical. So if there is no hearing, so there's no need to have hearing preservation, they go translabyrinthine. If it's intracanalicular, so only in the canal, then they'll have a middle cranial fossa approach. If it's in the CP angle, like our case, and in the medial internal auditory canal, then it's a retrosigmoid approach. I showed also DWI to show you that there's no restricted diffusion in this lesion. Here's another acute trigeminal schwannoma. So it's a small little schwannoma. You can see here on the image on the left. This is a T2 image, right where the trigeminal nerve takes off, and in the cisternal segment, you can see that kind of punctate area or rounded area of enhancement on the second image. T1 coronal images, pre and post contrast. You can see it's not enhancing, obviously. Well, there's no intrinsic T1 signal on the T1 pre contrast, and on post contrast images, you can see that little dot of enhancement, and that's a trigeminal schwannoma. So here's our next case. This is a lesion in the CP angle on the left side of the patient. On diffusion, there's maybe a little bit of restricted diffusion. That the ADC is a little on the darker side. On the image on the middle and on the right, the lesion enhances. So this is a meningioma. So meningiomas are also commonly seen in the CP angle, and they arise from the arachnoid cap cells of the posterior fossa dura. They are eccentric to the internal auditory canal, so they do not go into the internal auditory canal, unlike our schwannomas. So typically, meningiomas are gray matter iso-intense on CT and MRI. They can restrict on diffusion because they are highly cellular, and they enhance homogeneously, and they may have calcifications. Next case. So this is a CSF signal expanded in the left cerebellar pontine angle cistern. Different patient, same diagnosis. This time it's on the right side. You can see on the T1 images on the top left, the area is CSF iso-intense, and same thing on the bottom image on the T2 images, it's CSF iso-intense. Post-contrast images, axial and coronal, the middle and the left image, this lesion does not enhance. So it's following CSF, and it doesn't have any soft tissue component to it at all, no enhancement. Let's look at DWI. Okay, so we see the lesion on the right side again. This time it's restricting. So our diagnosis here, a differential diagnosis before the restriction, before the DWI would have been an arachnoid cyst or an epidermoid cyst. With the diffusion, we've confirmed that this is an epidermoid cyst. So the origin of an epidermoid cyst is basically the ectodermal cell rests. They are epithelial inclusions during neural tube closure and formation of secondary cerebral vesicles. They basically are stratified squamous epithelial linings around desquamated keratin. Most of them are intradural, and they can reach considerable size with minimal symptoms. So you need to be aware of that. All right, so that's epidermoid cyst. We'll move on to the next case. So I put a circle around the finding because it's very subtle. So the MR images here, so they're all post-contrast. You can see that there is enhancement in the distal intracanalicular, first genu, and labyrinthine portions. So those are the areas of enhancement that's not normal when you see intracanalicular and labyrinthine segments. So it's very important to follow the facial nerve, because this is what's enhancing on this patient, is the right facial nerve is enhancing. You need to follow the facial nerve through its entire course to make sure that there is no spread of tumor through the facial nerve. So you want to look at the parotid gland to make sure that there's not a mass in the parotid gland that has perineural spread up through the facial nerve. And if it's not, then you have to think of viral inflammation, possibly herpes simplex virus infection that is implicated. And in this case, the patient did have Bell's palsy. So this patient had latent herpes infection that reactivated and spread along the proximal and distal facial nerve. They can have intense asymmetric linear enhancement. And so you should mostly be aware of normal enhancement, which is very hard sometimes to differentiate between normal and abnormal enhancement. But basically, these patients' treatment is that they get a tapering course of prednisone, and they do pretty well. So another question for you about the facial nerve: how many intratemporal segments are there of the facial nerve? So there are 4. So we went over them. So it's the intracanalicular, the labyrinthine, the tympanic, and then the mastoid segments. And here's our last case. So this is an axial T1 without contrast image on the left and T2 image on the right. So you can see that there is T1 high signal, very high signal of T1 in the right petrous apex of this patient. The T2, there's also high signal, and then there's a low signal kind of peripheral rim, kind of posteriorly behind the lesion, and a little bit centrally. So basically, what you want to think about: what involves the petrous apex, and what is the differential diagnosis? So when we think about it, we have this laundry list of differential diagnosis, which goes from effusion, asymmetric fatty marrow, petrous apicitis, mucocele, cholesterol granuloma, congenital cholesteatoma, cephalocele, and tumors. So basically, this patient actually had a cholesterol granuloma. These are called chocolate cysts of the ear, or blue dome cysts. They're a special type of middle ear granulation tissue that's prone to bleeding and frequently cause hemotympanum. They are the most common cystic lesion of the petrous apex. There are several theories around how this is formed, but you need to know the imaging findings. So the high T2 signal and the high T1 signal is because of the cholesterol crystals that are located. The low signal is the hemosiderin on the T2 images. If these patients are symptomatic, then surgical excision is required, and that has to include the cyst wall or it will recur. I actually lied. We have one more case. I apologize. So the last case is a case where you have erosion of the posterior temporal bone here. It's basically in the vicinity of where the vestibular aqueduct is located. This is not my images. This I borrowed from Amersys. This is a similar case on the left side, though, of the patient, and it's a mass that's intimately associated with that posterior temporal bone. You can see here on the T1, there's some areas of T1 hyperintensity. On the post-contrast, it's heterogeneous. And you can see that there's growth into the internal auditory canal, which is indicated by the open arrow. And then there's middle ear extension as well. So this you need to be aware of. This is an endolymphatic sac tumor. Why you need to be aware of this is occurs sporadically, but more often than that, it's associated with von Hippel-Lindau. And von Hippel-Lindau is a stigmata where you have cerebellar and spinal cord hemangioblastomas, renal cell carcinomas, pheochromocytomas, renal and pancreatic cysts. In this case, when the endolymphatic sac tumor it develops, patients present with sensory neural hearing loss, and the treatment in this case will be surgical resection. So I want to thank you for your time, and I'll take any questions. I actually just realized I didn't put my email up on this, but I think we can share my email with you all.
Yeah, I can put your email in the chat shortly.
Okay, thank you so much.
Of course, thank you so much. So everybody feel free to put any questions you have in the chat or in the Q&A function at the bottom. So far, it looks like we have a question relating to one of the prior cases. So the question is, how do you differentiate cholesteatoma on CT if there is no erosion? Is MRI needed? Or and do you do MRI routinely to rule out cholesteatoma?
Yes. So if you cannot figure it out on CT, then I would recommend getting an MRI because the diffusion restriction will really help you make that diagnosis. So yes, get an MRI if you don't feel comfortable and you're not really certain that there's erosive change of the scutum or the ossicles or the tegmen, which is the roof over the middle ear cavity and mastoids.
Great. Okay, and then we have another question. In labyrinthitis ossificans, always uh, is the affected scala always tympanic? It's a sign that you can tell. Is it a sign that you can tell if it is tympanic or vestibular scala, the affected one?
Oh, you can't tell the scala based on the imaging. It's just that you have bony deposition in the cochlea, and that's what you need to look for, or in the vestibule or in the semicircular canal. So the inner ear structures get bone or ossify, and that's how you make the diagnosis. I was just sharing where it's most commonly seen when I was speaking.
Great. And then can you describe the Merkel's cave in a few words?
Meckel's cave. So that's a communication where the uh, is an opening that where the trigeminal nerve goes through. So that's I don't know if that's what you're asking, if that's what they're asking, Meckel's cave.
I think so. I
Yeah.
think that's what was being asked. And then another question is any dehiscence seen in the temporal bone? Is there a cutoff value or measurement of the bony defect for the diagnosis? I
Which
think that was for the
is it for
most,
superior and semicircular canal dehiscence? No.
I believe so.
It's a two
Um,
millimeter. If you're diagnosing superior semicircular canal dehiscence, you need to look at the coronal image, or if you do Prochelle images, look at it. If it's greater than 2 millimeters, then you would diagnose it based on that value.
okay. And then another guest is asking, how would you differentiate cholesteatoma, glomus tympanicum, and schwannoma in the lesions around the cochlear promontory?
Good question. So the tympanicum it will be a smaller lesion, but there will be no bony erosion. The cholesteatoma, as I mentioned, if you are suspecting it and you don't see bony erosions, you can do MRI. It would restrict. And what was the other one?
And glomus tympanicum and schwannoma.
Oh, schwannoma. Okay, so
Yeah.
schwannoma would also probably be small lesion. If it's large enough, you can see the cyst like we did with the CP angle. So that would help you. But sometimes it's really hard. MR is probably the best imaging to do because with the paragangliomas, you get the salt and pepper appearance that you would see on T1 and T2. So that would help you. And again, for a cholesteatoma, the diffusion would help.
Okay. And then can you give clues on CT for differentiation between facial nerve canal erosion and dehiscence?
Facial nerve canal. I don't know that it's the same. Erosion and dehiscence are sort of the same, I guess. And I mean, uh, uh, it's hard for me to answer that question.
Okay. No worries. Okay.
Because facial nerve canal, when you're looking at it, you're looking pathologically that there's something, taking away the bone that covers it. So in this case, a cholesteatoma, because it's in the middle ear cavity and the course of the facial nerve canal is close to it, you want to make sure that that bone is not eroded and that not invading the facial nerve canal. That's what I was saying when I was mentioning the facial nerve canal erosion.
Okay.
Or
If
these
anybody
questions.
else, yeah, if anybody else has any other questions, otherwise I'm about to put your email here in the chat for everybody in case
This was
they wish.
excellent. I think a lot of people have said this was such an excellent lecture. You
Thank
did such a
you.
good job. I think it's a very complicated
Yes,
topic. You did
it is.
so nice, which you just kind of simplified beautifully,
Thank
So
you.
it was an amazing lecture. So I really appreciate it. We have really got good response from people, who have really enjoyed this too. So I really appreciate this. And thank you everyone for joining today. Thanks, Christy, and thanks, Clara, for moderating. And,
Yes.
and we have Dr. Christy Lincoln's email in the chat box. So if anybody wants to contact her, we can do that. There was a question about the recording. It'll be on the. I put the link for the YouTube channel. If you subscribe to it, then you'll get an update when the lecture is uploaded. So, but this was very interesting. We also had people from Asia today join. So a lot
That's
of
great.
good response, even in the middle of the night. So
Yes.
thank you so much, Christy.
Thank
Really, really
thank you,
appreciate it.
Bhavya. Thank you, Clara. I appreciate all your time. I appreciate everyone's time on this, and allowing me to speak to you all. And thank you for all your questions.
Thank you. Really a really great lecture. Have a good day.
I appreciate you too. Thank you all. Bye.
Take care, everybody.
Thanks. Bye bye.